paper's open for questions. Wiley?
So if you look at the macular thickness, you lost a little bit of thickness, a little sawtooth effect, but it doesn't seem to affect the visual acuity. Do you want to comment on maybe the group was wrong, the overall room was wrong, that you don't need to close, get rid of all edema?
Correct. That's a great question. I think as retina specialists, we always want the retina to be flat. And I think from the data here, we can feel pretty confident that there's no visual loss. Now, there's been some recent data that has shown that fluctuations in retinal thickness may be associated with decreased vision. Recent analysis from the Hawk and Harrier studies showed that when you're in the fourth quartile, when you have a fluctuation of greater than 67 microns, that may be associated with vision loss in post-hoc analyses. I think the part that's reassuring from this data was the average fluctuation in the second year was 21 microns. And end of the day, when it comes to visual acuity, there's no loss despite that fluctuation, and in this case, it was only 21 microns.
Rahul, I know that the point of this presentation was maintenance over 24 months versus 12 months, but I didn't see any p-values in any of your comparisons of the different treatment groups on any of the slides. And when I looked at the 24-month data, the error bars for the at least for the 4 injections versus the 12 injections were pretty well separated. So there appeared to be a statistically significant difference in the improvement in visual acuity between 12 and 4. Could you comment on the actual benefit from a statistical perspective and how the study was designed?
Correct. So the statistics and the p-values were all predetermined before the study was done. And these were all preset, and these were at the 52-week mark. And those were set, and those actually showed a non-inferiority in stable vision and then change in visual acuity with the Q4 and the Q4 ranibizumab and Q12 weeks abicipar. Now, when you look at the 24-month data, those statistics were not set, and so that's why I didn't have any p-values for that when I presented. Although it looks like there's a difference, they've shown that they're non-inferior at that point.
There is non-inferiority?
Correct.
Rahul, if abicipar gets approved, how do you see it fitting into your clinical practice amongst the anti-VEGFs that we have currently approved or in use?
Great. I mean, that's a great question. I think neovascular AMD is a variable disease. I think all of us know that in practice. You know, we talk about 12 weeks. This seems to be the hot topic now, but I have patients that go 12 weeks of Avastin. We know from the second years of the VIII and II clinical trials, nearly 43% of patients with ranibizumab went 12 weeks. 50% with Eylea went 12 weeks. We've seen with Hawk and Harrier, in the Hawk study, 45% treated with brolizumab go 12 weeks in the 2 years of the study, and 39% go with Harrier, go 12 weeks in the beginning of the study. So clearly, with our current agents, nearly about 40 to 50% of patients can go Q12 weeks. The challenging part is that other half. And I think this data shows you that with a Q12 regimen, you can feel confident that these patients will do well for 2 years. And I think that's the area where I think there could be more work be done. And hopefully for those more resistant cases, this may give our patients another option.
Thank you. Thanks very much, Rahul.